Hi, welcome back to Gemma Network Open Live. I'm Seth Truger, Digital Media Editor at Gemma Network Open.
And I'm Angel Desai, I'm the JAMA Fishbein Fellow.
Of course, if you're following along live, please feel free to send us questions or comments at Twitter at Gemma Network Open, or you can respond in the comments on Facebook or YouTube. Apologies for our technical difficulties, happened sometime with a live stream. We are talking with the authors of Family Leave and Return to Work Experiences of Physician Mothers. And we've got authors Shannon Yangst and Isabel Huang. So welcome.
Hi, thanks for having us.
Thanks for having us.
Great. So tell us a little bit about yourselves and how you got interested in the topic.
Professor in the Physical Medicine and Rehab Department at UT Southwestern. And so I had children during residency. I have a 6-year-old and a 4-year-old. And out of my experience, I realized some of the difficulties going back to work, also some things that were good. And I heard, the same kind of mumblings from other physician moms. And I thought, you know what? Why don't we collectively have a voice together and see what's working and see what's not working? And so that's kind of how my desire to do this survey came about.
And I'm Shannon Yangst. I'm an assistant professor in PM&R at UT Southwestern. Also, I'm a researcher. I also have 2 kids about the same age as Dr. Huang's. And a couple of years ago, we shared an office for a short time, and we're talking about kind of the challenges of being working mothers, particularly in an academic medical setting. And this idea came about to really try to really thoroughly capture the experience of physician mothers, both the good and the bad, what works and where we need to make some improvements to better support them.
Mm-hmm.
Great. So it looks like for this paper, you had over 800 respondents from from 19 different specialties. So really across the board. And it sounds like from most of the other previous papers were either single specialty or small clusters. So tell us what you did and what you found here.
We had a unique way of creating the survey. We used a modified Delphi process where we had a panel of experts, including legislative individuals, nursing staff, academic, non-academic physicians, administration. So they really we created the survey, they gave us information whether or not these questions were pertinent, how important were these questions, and that's how we created the survey. And so we feel that the questions that we asked gave us a lot of rich data from the physician moms, and that was important to not just have a one-sided leading kind of questions. We really try to get both sides of everything.
It's great. And I think that there's what we presented here, which is a lot of data. It really thoroughly characterizes this experience, but we also had a lot of opportunity for people to share their experience as well, sort of through open-ended questions. And that's been both good and bad, exciting, but also discouraging at times to look through what those experiences are that people are having and sharing with us. And I think it's really captured in the statistics that we have in this paper, that there are still a really large percentage of physician mothers out there who struggled through pregnancy, through taking leave, through returning to work and not being well supported.
Mm-hmm.
I was really struck by, there were several things I think that hit really close to home, but a couple of things were that nearly half of respondents felt that they had someone who had recommended that they not become pregnant at a particular time during their training or in their work, which was really high. And then also 20% or 21% of respondents felt that they didn't even have the accurate information regarding their leave. And I'm just wondering if either those results or any of the other results that you came across sort of surprised you in the course of this work.
Sadly, it doesn't surprise me because I hear it. And, I've heard mumbles of, certain program directors prefer not to take females because of this, this issue of taking leave. So it doesn't surprise me. And we kind of just wanted to get it on paper, get a survey out and see really what percentage of women actually have experienced this kind of discrimination.
Yeah, and I think having clear policies and good information was something that really came across as lacking for a lot of people, that they weren't aware of how much leave they could take, what would be paid, what the policies were related to. For a lot of residents, there were some unique challenges related to how much time they could take off and delaying training. And so one of our kind of key take-home points was that we need to have policies in place so that people have realistic expectations and can make good decisions and plan, and that the information that they're getting is accurate, and that nobody is being surprised. I think that's one big area where systems could actually make a positive change, just to have set policies in place.
Yeah, I think when you hear that 73% of women felt that the leave time was insufficient, that speaks volumes in terms of what the physician moms are kind of facing. The leave typically for physician moms is 5 to 12 weeks. What they would have preferred, I believe, is up to 6 months would have been preferred. There's this myth out there that maternity leave is like a vacation time. And I'll tell you, the father of my child, who's a surgery resident, one time had to take care of my son when I was on call. And then my son was 3 months old, so he was very able to identify mom versus dad at that point. And pretty much he just screamed all night for mom. And when I came home, the father of my children handed me the baby and was like, you know what? I'd rather take trauma call. I'd rather not take baby call, because it was really hard for the baby to be separated by mom at that age for my baby. Yeah.
And I think we really captured that as well, going beyond just leave, but that return to work piece and what happens when you actually come back. That's when parenting, the hardest work starts.
Yeah.
And some of the big things that we found there were related to support for breastfeeding or pumping, and then having adequate childcare and the challenges that come along with having a new child or children, and the ins and outs and unexpected things that come up in terms of childcare. Those are big areas too, that there's not a lot in place to really support in every institution to really support working parents, and particularly it seems like mothers take on more of that, the burden of that.
Yeah, I think first-time mothers, 30% did not have an adequate place to pump. And then I think up to 40% felt discriminated with pumping. First child, 48%, did not have time to pump, right, or location to pump. So that's a problem. And I think, we want to open this up to more than just physicians for an occupation to look at. We're just starting with physicians. And I think medicine has a really unique opportunity to maybe set an example to say, how can we support these working moms, help them transition to continue to work and contribute to the medical society.
Yeah, I mean, I think this is one of those double-edged swords where there's so much just great and kind of a really good granular descriptive data here. A lot of it is very sad and describes a lot of the kind of grim realities that we face in how much we don't support women and parents and new parents. Having kids, maternity leave, coming back to work. I think there's I try to be an optimist. There's a lot of opportunities for improvement here, and cataloging it is really helpful. And again, it's I think we're trying to see the silver linings here. We're starting to see the last few years more of a national discussion about family leave, about expanding rights and things like that, and
changing the culture. Yeah, changing the culture.
Exactly.
Yeah, no, I was, one thing I just kind of wanted to go back to that you mentioned is I feel like one of the themes that kind of emerged from this is just not that much information that's easily accessible to people when they're going through this. I know for me, I remember when I was going through my maternity leave and just trying to figure out how much time I actually got off and how, all of the procedures that went along with that. I remember talking to 3, 4, 5 different people, and there just wasn't a lot of knowledge there, or there wasn't a centralized place to get that information.
Yes, absolutely. It's different institution-wise, different per practice. And I think, not having any paid leave, it's very difficult for some of these physician moms. We still have loans to pay for. You still have to live and feed your family and your children. And some of these moms are taking time off, and they're still having to collect overhead of their practices and being penalized or delaying their ability to get promoted because of, maybe it's based on RVUs, and when you're not working, you're going into negative for RVUs. So all these kinds of issues. And I know I've heard of private institutions that have actually changed and been more supportive for their physician moms. So I have hope that I think that is something that can happen because I've seen it happen before. It's possible, and that's why we wanted to do this paper, to start a conversation, because that's the first thing that has to happen, is to start a conversation about this.
Yeah, and unfortunately, in the current status quo, where there's not a lot of information, where even though there are theoretical or legal protections or theoretical limits or rights, et cetera, when it's not clear exactly what can be done, when this is kind of when the hidden curriculum and a lot of the implicit stuff takes off.
Yeah.
And throughout, one of the themes I noticed through here is things like derogatory comments or pressure from coworkers or things that aren't not people frankly being denied their rights, but little insidious ways that new moms are undercut.
Right.
I've heard countless stories about women, where technically there's a pumping room, but it's not a room that anybody would ever want to sit in, and it's not in the place. And you're still, again, you're not collecting RVUs during that time.
Right. Yeah, exactly. So.
Yeah, and that was a theme that really came up, was the sort of penalization after the fact, whether it was
more
specific or intentional, but our penalization based on RVUs or on having to make up call time. So you come back after being on leave, and now you have to put in extra call, and people sharing stories with us about having to work 60 days in a row with no days off because they were making up time. And when you have an 8-week-old at home, that may be extra challenging to work a schedule like that. So I think there's implications for health and well-being of these women. And as Dr. Huang said, it really extends beyond medicine. This is an issue for working moms kind of across the board.
Yeah.
But in healthcare, if we can't take care of our workforce, how can we expect to then extend that out and take care of others? We should really be a leading example, not in institutions that are maybe lagging behind.
Yeah. Definitely an opportunity for medicine to kind of, show that they can provide care for the physician moms, the physicians that are taking care of the patients. A recent study that was published showed that female physicians actually had less readmissions and less mortality rates for patients 1 month after they were discharged from hospital. So those are some good doctors there. We really want to keep them in the medical field.
Right. Yeah.
I like that. An optimistic note.
And
things to strive for.
I'm glad you also talked about miscarriages, because I think that's one of those things where we see them all the time. It's something we do a lot in the emergency department where I work, and it's we just don't really talk about it very much, and it's clearly a salient issue, especially a lot of women in training are of childbearing age, et cetera.
Yes.
And in your survey, nearly 30% of women had a miscarriage. Only about 40% were able to take any time off.
Yeah.
And oftentimes, even in the best case scenario, there's still not just the emotional issues, but the medical issues.
Yeah. I mean, I think that's a really great point. In general, it's a topic that we just don't talk about much on a cultural level, a broader level. There's something that, I don't know if it feels taboo or uncomfortable, but people just don't talk about it. And so I think it's really important, again, to have that conversation. We've had people since this came out just a couple days ago already reaching out to us and sharing their stories. And that was one of the things that seems to really resonate with a lot of the people who have read the paper so far. These women who have said, this was my experience, and stories about why they didn't take off that time. And when they did, the kind of negative experiences they had with being judged for taking off. Mm-hmm. The time to go through that experience. So I think that's another, that in and of itself is a whole conversation.
Right. Yeah. Yep. All right. Well, thank you again. This is just a fantastic study, and I've got notes all over because it's just there's so much great stuff in here. So thank you for doing the study and publishing it in JAMA Network Open, and thank you so much for joining us today.
Thank you for having us. Thanks.
Good. All right. Well, on that note, moving on,
Yes.
changing gears just a little bit to talk about transverse myelitis, an area which I don't know if anybody has any actual content knowledge or expertise. But I like this paper just because we see transverse myelitis.
Yeah.
It's certainly something that happens. It's every time it comes up. It's I remember how little I know about it.
Exactly.
This one gets a little bit more into the weeds, but basically they talk about two specific subtypes of transverse myelitis: the myelin oligodendrocyte glycoprotein antibody and aquaporin 4 antibody disease, or MOG, and AQP4 disease. Basically, these two subtypes of transverse myelitis syndromes what people have. They looked at 115 different adults who have these two immunological-based diseases, just to kind of describe some of the differences. Some of the things they found were that the patients with MOG overall did better at recovering their mobility, but did have more sphincter dysfunction, which is a big quality of life issue and a big functional problem for people. There's an interesting figure that shows where the lesions are, whether they're cervical, thoracic, or in the conus medullaris, and then the figure here separates them out by whether or not they have sphincter dysfunction and require catheters, long-term catheterization. And basically, I mean, this is more descriptive than anything else,
Right.
but it sounds like this will be interesting in patients who are diagnosed with transverse myelitis. It's interesting. It's good to have some good prognostic and kind of predictive data on where things are going to go in the future.
Yeah, I don't know if I have much more to say about it, but I actually didn't realize that there were these different sort of, not necessarily subtypes, but different sort of characteristics behind transverse myelitis. So I think that's really interesting. The one thing I didn't, I couldn't quite glean is that these processes are completely different, correct?
I think so, yeah. Yeah, I think, I mean, as best as I can tell, as a very much a non-expert in transverse myelitis, it's basically a syndrome that happens, and there's a bunch of different, I guess, disease causes, and these are two antibody-mediated versions of it. Apparently, there's also some overlap with neuromyelitis optica.
Right,
and there's some thought that MOG is either a subtype or a mimic of the neuromyelitis optica spectrum disorder syndromes. I don't know. It's it's complicated stuff. But I'm not going to pretend to be an expert or see patients with this all the time. I did see a patient with transverse myelitis not too long ago.
Oh, really?
And the patient had basically had exacerbations before. This is one of those. The patient's one with the disease. They know their stuff. He knew his stuff really well.
Yeah.
There's a lot of So is this what typically happens? Yeah. But yeah,
Great.
it's again, not a fun disease,
No.
but nice to have more information about something that we don't know a lot about.
Definitely.
And by we, I mean me.
Us. Exactly.
All right, moving on.
Okay, next up, it's the Association of Estimated Pulse Wave Velocity with Survival, a secondary analysis of SPRINT. So this is a post hoc, as the title suggests, secondary analysis of the SPRINT data, which was a trial from several years ago that looked at whether or not targeting lower systolic blood pressures would sort of correlate with lower rates of fatal and non-fatal cardiovascular events, which they found that it did. And so this study was trying to look at use this data to see if aortic stiffness, as estimated by something known as pulse wave velocity, is also predictive of cardiovascular events in patients with hypertension. And so they found that using estimated pulse wave velocity did in fact help predict all-cause mortality as well as worse cardiovascular outcomes, independent of the Framingham risk score. And the point of kind of looking at this marker or predictor was that things like the Framingham risk score, which we use all the time, isn't necessarily always optimal in every situation. The other thing that it found, and you can see this in figure 2, is that in the group that had the more intensive therapy, they sort of had a concomitant reduction in their estimated pulse wave velocity, and they also had the best prognosis in terms of all-cause events. So very interesting, just kind of another potential tool in our toolbox.
Right. Absolutely. So going to welcome Sarah, who's joined the feed. We're talking about this estimated pulse wave velocity from the secondary analysis of SPRINT. Now, I remember SPRINT because when it came out, before they published the study, when the study had finished, they had a news release disclosing the results and saying like, look how what we found, we have to change treatment. This is before it even went through peer review. So there's a little bit of a controversy with that. And just, I don't do a lot of these kind of measurements, but it's interesting. So estimated pulse wave velocity is a proxy for carotid femoral pulse wave velocity, which isn't hard to measure, but it's easier just to do this formula that's really just age and mean blood pressure, which is something that we can do very simply. And to me, I think the potential eventual difference here is if instead of just looking at blood pressure as this one set of numbers, if this is a little more granular way, and if certain patients do better with certain treatments or certain modifications of certain targets instead of just systolic, diastolic, and MAP,
right?
It might be helpful down the road.
Definitely.
But again, it's a reanalysis of a secondary. It's a secondary analysis. It's post hoc. This is hypothesis generating.
Yeah.
So I'm certainly not estimating anybody's pulse wave velocities yet.
Maybe in the future.
Okay. All right. We've got Ambarish who's joined us. Welcome. We're moving on in our table of contents rundown to the evaluation of injury severity and research utilization in pediatric penetrating trauma. So this is an interesting study. They looked at the National Trauma Data Bank, big national database of not every trauma, but it's pretty comprehensive. From 2007 to 2016, 780 hospitals, a couple dozen were pediatric only, about nearly half were associated with pediatric hospitals. A total of 25,000 firearm injuries in these kids, 21,000 cutting and piercing injuries. And just looked at some of the different characteristics, because not all penetrating trauma is the same. Not surprisingly, firearm injuries are more severe. Some of the differences: 85% versus 75% of the firearm injuries were male, and 75% versus 50% were in the 15 to 17 age group. So the older kids. And basically what they found, and I'm just going to quote from the study here: critical and non-critical firearm injuries were associated with higher likelihood of ICU admission, a higher injury severity score, and higher likelihood of longer hospital or intensive care unit length of stay compared with cut or pierce injuries. So not surprising.
No,
it's worse to get shot than get stabbed.
Yeah.
We could get into some methodology stuff about how patients with gunshot wounds are probably more likely to get advanced imaging, and there's some ways that can round up your ISS scores, et cetera.
Yeah.
But overall, just it's we lump penetrating trauma together a lot of the time, but being shot is definitely worse for you.
Yeah, I was just surprised and also not surprised, I guess, about the numbers that they found in terms of all of the encounters. I think you mentioned 25,000 firearm injuries, which is substantial.
Yep.
And the other thing, which I think kind of goes into the methodology, which I just thought was sort of interesting, was that they didn't include patients that had passed on the scene, and that is more likely to occur with people that have had a firearm injury. So this is actually potentially an underestimate even.
Yeah, and by definition, the people who die at the scene are the sickest.
Right, exactly, yeah.
Yep. All right. Great. What do we have next?
All right. So the feasibility of using real-world data to replicate clinical trial evidence. So this was trying to identify the number of clinical trials published in the top 7 highest impact medical journals in 2017 that could be replicated using observational data from things like insurance claims and EHR. And they looked at essentially 220 US-based trials and found that 15% of these could actually be replicated using observational data. And that if you look sort of overall, 39% of these trials, or the 39% of those that could be replicated, had an intervention that could be ascertained from this observational data. And so potentially, there is a possibility that real-world evidence can complement clinical trials. I mean, the number 15% is still pretty low, to be honest, but it was sort of interesting for me to think about the fact that, clinical trials are expensive, they take a lot of time, and so maybe there's a role for real-world data in some of this.
Yeah, and one of the things to me, and they talk about it in their background, is how a lot of times with the inclusion and exclusion criteria of clinical trials, it's often not representative to the real world patients that are patients are usually younger, fewer comorbidities, no kidney injury, things like that, in the clinical trials. So some more context for this is the 21st Century Cures Act of 2016 basically directed the FDA to get guidance on doing using real world data to basically use observational data, big EHR studies, administrative and clinical data, and basically I think my big takeaway here is that they found these 220 trials which they could get the data for, but only about 33 trials out of that 220 could get all of the different aspects that you could from these kind of administrative databases, and some of it's there are ICD-9 codes, but there's not one for severity, so you don't know if it's a patient with severe pneummonia or whatever it is.
Right. Always a limitation of this.
I was actually really amused that one of the limitations was that you couldn't replicate trials with drugs that weren't approved yet.
Oh yeah.
Which is kind of like, this is like, they're snaking its own tail now. Right. All right. So moving on, this is a research letter on Indiana's Section 1115 waiver Medicaid expansion. So Indiana, which is generally a fairly red state, didn't do a traditional Medicaid expansion. They did one with an 1115 waiver. And they basically got approval to do things like charge premiums to Medicaid enrollees, do copays for non-emergency ED visits, which I could talk about at length about why that's a very bad way to dissuade people from getting appropriate care, as well as financial incentives for healthy behavior, which again can lead to certain problems, like certain people aren't able to do healthy behaviors because of medical limitations and disability and things like that. But basically what they did is they did a difference in difference analysis versus other states that did just a normal traditional Medicaid expansion, and not surprisingly found that while this Medicaid expansion in Indiana under the waiver did lead to some uninsured people getting coverage, it was about 3.5 percentage points across the state population fewer than if it would have been a complete Medicaid expansion.
Yeah.
Which is not a small amount.
No, definitely. I was wondering I don't know if you know, but was the state of Indiana unique, or were there other states that have done similar things like this?
I don't know the exact detail. I know a bunch of other states have done expansion, have done the 1115 waivers, and these are kind of just policies, like on the menu of policies that the market-oriented Medicaid expansion places try to do, but it's all across the board. But I think there's generally about half a dozen states or so that have done the 1115 waivers along this roughly the same idea, but this stuff gets really technical, and I'm sure that I'm wrong on some of it. So chime in online if you want to correct me. All right, next up, this is an interesting paper that looked at trends in high and low value cardiovascular testing in fee-for-service Medicare from 2000 to 2016. So this gets a little bit wonky, but basically in the late 90s, early 2000s, there was a big increase in diagnostic cardiology testing. Some of it was, hey, we've got this great technology. Let's try to do things like nuclear stress test or echoes or things like that. Some of it was also just the rise of stress tests to do things like shorten overall hospital stays, et cetera. But basically, Medicare was finding they were spending a ton more money on this testing, a lot of it which was against guidelines. So what the authors did here was look at the 5% Medicare sample that's available for this time period, and looked at high value versus low value testing. So the high value testing they did were measuring EF after an acute MI or CHF diagnosis. And then the low value testing looked at was stress tests before lower surgery or routine stress tests in the absence of symptoms within 2 years of getting revascularization. And basically most of the answers in figure 3, if you look at all the concern here, more the context was that if they're changing the payment structure for these tests, is there going to be a spillover effect where by discouraging low value testing, are they also going to discourage high value testing and have that unintended consequence? And basically the answer is no. If you look at figure 3A, you see the big curve, that overall testing did continue to increase but then tapered off a bit. And when they divide it up into the different types of tests, you can see kind of more granular data. And then basically some of the trends, you can't see it in these graphs, but some of the trends continued to go up a little bit but then did go down. The low value testing basically did drop off more, and the high value testing did continue to rise appropriately.
Now, and is high value, so these definitions for high value versus low value, right? Is this something that is are these definitions accepted across the board, or because I could imagine that there might be some discrepancy or there may be some argument about some of this.
Sure. So my understanding with these are generally pretty much at the far end of the spectrum of things that everyone agrees you don't need to get a stress test before you have like a glaucoma surgery.
Sure.
Or if you have a heart attack, it's pretty reasonable to get an echocardiogram to see what your EF is after. If you're even to diagnose CHF, like maybe we want to know what your EF is. There's a lot of things there. A lot of the times, we're pretty cautious about calling things high value or low value.
Right.
This does not seem to be in that gray area. So it seems pretty reasonable based on my knowledge of this stuff. So that was good. All right, so moving on. Next up, we've got Association of Family ratings for quality of end-of-life care with stopping dialysis treatment and receipt of hospice services. So this is a VA study. They looked at 111 VA hospitals from 2009 to 2015. They had 3,400 patients who died with an average age of 70, and these were all patients who were getting routine dialysis. So 28% stopped their dialysis before death. 60% of those who stopped the dialysis were in hospice versus 20% in those who did not stop dialysis. What they did was they did these basically quality surveys with the families, asking how was your family members' end-of-life care, and they found that for those who stopped dialysis, it was 10 points higher, so 55% versus 45%. For those who did continue dialysis but did initiate hospice, there's a 20-point difference. So 60% of patients' families rated their end-of-life care as high quality versus 40% when they didn't get hospice involved.
Yeah, I thought those numbers were pretty incredible, and I also thought, from just a personal perspective, the families of those who did not elect to stop dialysis. Or that did stop dialysis, I should say, and then also had hospice services, they actually rated the clinicians taking care of them as better, or not better, but taking more time to listen to them, giving them more support. And I think that really sort of speaks to the power of palliative care and utilizing hospice services better than we do right now, in a wider variety of settings.
Right, and it's really hard to know the correlation versus causation there. Is it that because the doctors stop the dialysis or initiate hospice, they're better, or is it just that doctors who are better communicators are more likely to be respectful of end-of-life wishes, or just they're better at communicating overall, or vice versa? Who knows? But I'm a very cynical optimist. There's lots of room for improvement in end-of-life care.
Definitely.
And more that we could do or even stop doing.
Yeah, definitely.
Yeah. All right, and what's next?
Okay, so I think last we have the Association of Neurocognitive and Physical Function with Gait Speed in Midlife. So this was a cohort study from New Zealand. I wanted to name the actual study, but I don't know if I can pronounce Dunedin.
Dunedin?
Yeah, Dunedin. Yeah, study. And they wanted to look at how gait speed essentially reflects biological aging, and as well as cognitive decline. And so they found that slow gait speed, or adults with more physical limitations and smaller brain volume and more cortical thinning, which you can see in Figure 3, actually had slower gait, which was kind of interesting, I think.
Yeah, and I'm certainly not an expert in this Jerry functional literature, but apparently gait speed is kind of a well-described marker of cognitive decline as we age and get older. And one of the things that's interesting here is they were able to spot it even when they were 45.
Right,
so even in midlife, they were able to kind of use it as a marker of kind of overall cognitive aging.
Yeah.
Which is interesting. And unfortunately, I might start paying attention to my gait speed in a few years.
I know. Exactly.
All right. Well, thank you for joining us. You can, of course, read these papers and more at JAMANetworkopen.com. Everything's free and open access. We've got new papers coming out Wednesday, tomorrow at 10 a.m. and Friday, 10 a.m. Central Time. Join us next week, Tuesday, 3 p.m. Central Time again. Editor-in-Chief Fred Rivara should be joining us as well. And, of course, follow us on all the social media channels, Twitter, Facebook, LinkedIn, Pinterest, all the fun stuff at JAMA Network Open.
Bye.
All right. Take care.